ticking in the embryology lab. Your chairs today are myself, Rachel Gregoire, and I also have Gemma Arroyo with me. We're going to start with our first presentation, who is Frederica Moffa, and she's going to be talking about timing matters, the warming ICSI interval influences oocyte viability. Over to you.
Thank you, and good afternoon, everyone. First of all, I want to thank the ESHRE Scientific Committee to select our job for oral presentation. I present on behalf of Francesca Lolicato, who is the first author of this work, but she unfortunately could not make it to be with us today. And I present a retrospective study entitled Timing Matters. The warming ICSI interval influences oocyte viability and blastocyst yield in a multi-center study on 3,291 vitrified oocytes. Okay, it's maybe here. I'm sorry. Okay, so first of all, I declare I have no conflict of interest with this presentation. And so the study question we wanted to address is quite straightforward and has clinical influence and impact. So does the warming ICSI interval influence oocyte viability and blastocyst yield? We all work in the lab with vitrified oocytes, but there is no consensus about the time we have to wait between warming and ICSI procedure. So we know that the disruption of the meiotic spindle is occurring during cooling, and it can reform after warming at physiological temperature, supporting normal fertilization and embryo development. But also, we know that prolonged culture after warming may accelerate in vitro oocyte aging and reducing developmental competence of the oocyte. So there is a narrow window, and the human oocyte appear to have a limited period in which both fertilization potential and developmental competence are preserved. And previous studies are inconsistent, and we have findings that pointing to that a short interval would be beneficial, but other study pointing toward a longer time after thawing be the best interval. So we are an IVF clinic, Fertilab, based in Barcelona, with an in-house bank, FertiBank. And the retrospective study included a free collaborating center in Italy and our own lab. So we analyze data proceeding from 3,291 vitrified thawed oocytes, leading to 338 ICSI cycle from January 2020 until October 25. It's very important that all the oocytes are proceeding from the same bank, FertiBank. The mean age of donors was 24.8. And all the oocytes were vitrified 2 hours after egg retrieval. To reduce for confunders, we exclude cycle with male factor infertility. So the analysis included just the survived oocyte after thawing, and the main variable observed was the warming ICSI interval. It's very important to know that it was not pre-selected. On the contrary, it was determined by the routine laboratory workflow of the center. And the main outcomes were the oocyte degeneration rate after ICSI procedure, the fertilization rate, and the usable blastocyst rate per fertilized oocyte. The statistical model we applied was the generalized estimating equation to reduce for confounders and correct by center and oocyte age. So the main outcomes were not statistically different between the center, and we had fertilization, the survival rate after thawing ranging from 84% to 91.8% within the center, and also all the other parameters were not statistically different between the center, as post-ICSI degeneration rate, 2PN fertilization rate, abnormal fertilization, and usable blastocyst rate per fertilized oocyte. The interval ranging from a minimum of 35 minutes after thawing and maximum of 627 minutes, with a mean warming ICSI interval being 156 minutes. So, based on our model, we observe that each additional 60 minutes that intercur between the thawing and the ICSI procedure increase by 21% the risk of degeneration of the oocyte. It means that if the degeneration rate of the oocyte after 1 hour is 3%, if we wait until 4 hours to perform the ICSI, we increase this risk to 5%. And on the same trend, but inversely, we have the fertilization rate decreasing from 82% if we perform the ICSI at 1 hour, going low to 75% if the ICSI is performed at 4 hours. And the same thing for the usable blastocyst per fertilized oocyte. So each additional 60 minutes decreased the odds of the usable blastocyst by 8%. So an oocyte fertilized 60 minutes after thawing, it was 72%, and it decreased to 65% after 4 hours. So we can conclude that a longer warming ICSI interval significantly increased oocyte degeneration after procedure of ICSI and reduced the fertilization and usable blastocyst rate. The warming ICSI interval is a modifiable factor that can influence the oocyte competence and the blastocyst yield. And so based on our data, we think that the best time frame to proceed to ICSI after oocyte thawing is 1 hour post-warming. So optimizing laboratory workflow to minimize delays, improve efficiency in vitrified oocyte program. We would like to thank all the collaborating center in Italy and all the people in our lab. Here's a picture of the biologists in Fertilab. And if you have any very technical question, you can write to Francesca, that she will be very happy to answer to your question.
Thank you. Thank you very much for this presentation. Now it's time for questions.
It's
It's too high microphone. Thank you for the excellent talk. I was just wondering, what's your methodology post-retrieval? Do you wait for a couple hours, then you freeze the eggs, or you freeze them straight away? So your ICSI time, would it be 40 hours post-retrieval?
Yeah, so if 40? No.
40 hours post-retrieval.
Post-trigger.
Sorry.
Okay,
Sorry.
okay. So we normally retrieve eggs at 36 to 30, 35 to 36 hours. We are very narrow in the window of egg retrieval after trigger in the donor program. So then we wait approximately 2 hours after retrieval to freeze. So it's 35 plus 2 or 36 plus 2 before freezing.
Thank you so much.
Hi, Julia Raji from Germany. I just wanted, thank you very much for your talk. I just wanted to ask, I'm over here. I just wanted to ask if you have any more time points that you compared. Like, did you try 30 minutes after thaw, 90 minutes, or was it just 60 and 240 minutes?
No, this is retrospective. Yeah. So the time, it was not like
planned,
pre-established. So we collect data from different centers. So it depends on the center. We had some oocyte that was fertilized 10 hours after the egg the thawing, sorry. So it's really, we collect the data retrospectively.
Okay, thank you.
So the minimum was 35 minutes, and the maximum was 627 minutes after thawing. But the mean time between all the center, in all the sample was 150. I can show you back. No, it's going back this way. So it was 156.
And was the trend completely linear, or was there like a peak at a certain time?
Okay. This is a model, so a statistical model that it's in the model it's linear. So each 60 minutes you have a linear increase in the generation or decrease in fertilization and blastocyst. But it's based on a statistical model.
Okay, thank you.
Yeah.
Okay, thank you very much. Thank you very much. If there is another question then. Short question, please. No? No. Okay, so thank you very much.
Thank you.
We will move now to the next presentation. Mrs. Chen Xung from the hospital in Chongqing, China, will talk about the prolonged timing between the pickup and the denudation, and in correlation with the blastocyst LPD.
Okay. Thank you for your introduction, and good afternoon, everyone. And today, hi, everyone, I'm glad to be here. I should begin with my clarifying that today's presentation is the work of my colleague. The original presenter, Shun Xun, was the primary investigator on the study, so unfortunately, she can't make it in person. So I have to ask to deliver this talk on her behalf. So our object is prolonged OPU to DN interval reduces euploid blastocyst yield in PGTA cycles. something. It can now to went on next. So,
Okay. Yes, if not, use this. Try.
okay, thank you. Okay. So it's our introduction. We all know that ICSI procedure involves 3 key time intervals from the HCG to OPU, from the HCG trigger to outside pick-up. And OPU to DN means that so from the outside pick-up to denudation. And DN to ICSI means that from denudation to ICSI. Also, these intervals have been studied, and there's impact on embryo development, and the clinical outcomes remains inclusive, so particularly regarding the euploid outcome. So our objective is to determine whether the OPU to DN interval influences the absolute number of euploid blastocysts per cycle in PGTA. That's all materials and methods. Our design is a retrospective single-center cohort study, and our primary endpoint is the absolute number of euploid blastocysts per cycle. Our analysis method is a multivariable regression and validation analysis. And is this a criteria? The inclusion criteria is PGTA cycles with ICSI insemination, and there is exclusion criteria, cycles with sold embryos for biopsy and PGTA, and cycles with PGT for PGTM or for the strigo rearrangement PGT-SR, and a total of 1,502 PGTA cycles was included in our study. And this is the results. First, we see the ICSI procedure intervals and laboratory parameters, and the figure shows the association between the ICSI intervals and laboratory outcomes. And we show the correction and the laboratory parameters, including the outside degeneration, numbers of the blastocysts formed, and numbers of euploid blastocysts, and M2 outsides. Among the 3 ICSI intervals, we can see the OPU to DN show the strongest negative association with euploid blastocyst yield, and each 1 hour increased OPU to DN interval was associated with a reduction of 0.1 euploid blastocysts per cycle. However, we can see that HCG to OPU and the interval of DN to ICSI were not associated with euploid blastocyst yield. And these results show that OPU to DN interval as a strong predictor of euploid yield. So, we focused on the OPU to DN interval to see whether it can be a predictor of euploid yield. And also we can see that HCG to OPU and DN to ICSI was not mainly associated with euploid blastocyst yield. And this another result was about the surviving embryos. We can see the OPU to DN and the competence of the surviving embryos. And the table showed the correction between OPU to DN and the blastocyst development and the clinical outcomes. The results demonstrated that this interval was not associated with the blastocyst formation rate, biopsied blastocyst rate, euploid blastocyst rate, and the ongoing pregnancy rate. And these results indicate that the surviving embryos retain competence regardless of the OPU to DN reduration. So we can see a little conclusion here the OPU to DN interval did not significantly affect the blastocyst formation rate, the euploid rate per biopsy blastocyst, and the ongoing pregnancy rate. So it's retained the competence in the surviving embryos regardless of the OPU to DN duration. Also, we want to see whether the oocyte generation mediates the effect. Given the observation of prolonged OPU to DN interval with both increased oocyte degeneration and reduced euploid blastocyst yield, we formed a mediation analysis to test whether the oocyte degeneration mediates this relationship. When the oocyte degeneration was included in regression, the direct effect of the OPU to DN interval on euploid yield was attenuated and become a non-significant factor. In contrast, the indirect effect through the oocyte degeneration remained significant and account for over 40% of the total non-negative effect, establishing the oocyte degeneration as a key mechanism mediator. This result we can see from the figure. So, then we can see the prolonged OPU to DN interval progressively depleted the cohort. And the mediation analysis showed the direct effect of the OPU to DN euploid becomes non-significant after including the oocyte degeneration, and the indirect effect via degeneration accounting for the 38.2% of total effect. So we can see that the oocyte degeneration is an important mechanism mediator. Furthermore, we found that except for oocyte degeneration, longer OPU to DN led to the increased zygotes, fewer blastocysts, finally result in the fewer euploid blastocysts, the outcome result we can see. So we proposed that it is likely reflects a dose-dependent continuum of oocyte compromise. At the shorter intervals, the main effect maybe is the oocyte loss. We can see some degeneration happened beyond a critical cutoff. The development competence of surviving oocytes may also be impaired. And also, we also acknowledge that further research will be necessary to collaborate our hypothesis. We can also see some limitations. For example, it's a single-center retrospective design may introduce selection bias and limit. Also, there's unmeasured confounding factors, and also the restricted at a specific OPU to DN time window. Findings may not apply to more the prolonged delays beyond a critical threshold. Also, for the retrospective multi-center studies with standard timing and mechanism assets are needed. And also we can see the conclusion here. Prolonged OPU to DN intervals reduces the absolute numbers of euploid blastocysts, but not affect the rate. The primary mechanism is oocyte degeneration, not the impaired embryo competence. Also, the clinical implication minimizing the OPU to DN time may help to preserve euploid blastocyst yield. Also, at last, we sincerely apologize that our author, the principal author, cannot attend in person. We have always cherished the spirit of academic exchange So I'm presenting on my colleagues' behalf. So in order to give you more accurate answers to your questions, we also left the author's email address here for further communication. And we sincerely appreciate your understanding and support. Here is the email. Thank you.
So it's time for questions. I think that we have a question there.
Thank you, presenter, for your good presentation. But I would like to understand your recommendation. Which is the better now to approach to we have to use between OPU, DENU, and white for 2 hours prior ICSI, or you needed to do OPU, white for 2 hours, then DENU, then follow ICSI. What is your recommendation regarding this?
We want to say that you can see there is several intervals from the ECG to ICSI to the blood sources biopsy, and we draw the line. It's not simply like over 3 hours is bad or less than 2 hours is good. It's not simply like that, because we have a narrow intervals between that. So the further studies is needed. Thank you.
There's a question on here.
Okay, there is a question on the slide.
What was the denudation protocol in your study? It's here. I'm here. It's a question online. What was the protocol for denuding the eggs? The protocol, the process. How did you denude the eggs?
It's a retrospective studies. So you mean the intervals, the time?
No, how? What process did you use to denude the eggs? Is it just mechanical?
Mechanical and chemical.
As the chemical, you applied blood sources.
So the denudation, the stripping of the eggs?
Yes.
How did you do that? With
maybe the questions you can email to our authors.
Okay.
Thank you.
Okay.
Thank you.
Okay. Okay.
Okay.
Thank you very much.
Thank you. Okay, we have our next speaker, and we have Orhun Isikoglu, who is going to talk to us about day after rescue ICSI. Is it an effective strategy to overcome total fertilisation failure? Thank you.
Dear chairpersons, colleagues and participants, my name is Orhun. I'm a final year medical student. In a couple of weeks' time I'll be graduating, so it's an honour to be presenting at ESHRE before officially becoming a doctor. So total fertilisation failure is the most scary and frustrating situation in ART, which can compel practitioners to prefer ICSI over conventional IVF, even in non-male factor infertility. So today I'll briefly compare the two insemination techniques with evidence-based data. I'll then present our own experience and discuss whether late rescue ICSI can effectively overcome TFF. I have no conflicts of interest. So let's first of all consider the current stance of international guidelines on ICSI. The recent ESHRE recommendations consider ICSI in non-male factor infertility as an add-on treatment and do not recommend its routine use. ASRM and NICE guidelines have similar recommendations, and the ESHRE guideline on unexplained infertility also advises against the indiscriminate use of ICSI. And importantly, ICSI has not been shown to improve outcomes in these patients and may even carry certain disadvantages such as increased costs, more laboratory workload, and also the risks associated with oversight manipulation. Despite lack of evidence supporting routine use of ICSI in non-male factor infertility, its use has increased dramatically in Europe over time, whereas conventional IVF, after a continuous decline, has reached and remained stable at around 30%. And if you look beyond Europe, we can see a similar picture emerging, like in America, Africa, and Oceania. In the Middle East and certain countries in Europe, conventional IVF is almost never used. Only in certain parts of Asia do we see somewhat higher rates of conventional IVF use. So there's clearly a gap between what the evidence suggests and what's happening in everyday clinical practice. And if you look at the European registry data, conventional IVF has achieved higher pregnancy rates than ICSI since 2008. And what the small advantage that ICSI has before 2008 is likely because of historical treatment patterns when ICSI used to be used for clear male factor indications and conventional IVF for the same thing as well. So is ICSI really better than conventional IVF in non-male factor infertility? In almost every clinical scenario studied, conventional IVF has provided outcomes that are either similar to or even better than ICSI. Two major concerns that seem to prevent many practitioners from using conventional IVF are fertilisation rates and TFF, but both of these parameters are also comparable between the two techniques. Plus, if TFF does occur after conventional IVF, then rescue ICSI is a backup option. Ironically, now a lack of experience may be emerging as a modern indication for routine use of ICSI. As we've already seen in parts of the world, conventional IVF is very rarely used, so there may well be a gradual decline in expertise in performing conventional IVF. In terms of how the two techniques are compared, the ESHRE alpha consensus provides some valuable key performance indicators, but also contains some pitfalls. So when normal fertilization rate is calculated, for example, the denominator for ICSI is the number of injected metaphase to oocytes, but for conventional IVF, all inseminated COCs are included. So the comparison is not equivalent from the outset. Secondly, TFF is presented exclusively as an IVF-related issue, but it can happen in ICSI as well. And thirdly, the risk of oocyte damage in ICSI is often overlooked, which is a well-recognized risk of ICSI. So when the techniques are compared, I think it should be made on equal terms. So if we go into a bit more detail about some of these pitfalls when fertilization rate is calculated per inseminated oocytes, ICSI seems to be better since immature oocytes are removed during denudation. However, when we change the denominator to number of collected COCs, the fertilization rates are reported to be similar or even higher with conventional IVF. So this denominator effect causes somewhat a therapeutic illusion with ICSI. And in terms of TFF, it's not an IVF-specific issue. There's 4 major RCTs and most systematic reviews and meta-analyses have shown similar TFF rates between conventional IVF and ICSI. So that was conventional IVF and ICSI. I'll now move on to how we do conventional IVF in our clinic. Once the COCs are collected, semen is prepared using density gradient centrifugation. About 2 to 4 hours after collection, the COCs are inseminated and incubated overnight. And 18 to 20 hours later, fertilization is assessed by the presence of 2 pronuclei. And any mature oocytes that haven't fertilized may subsequently undergo rescue ICSI. There's also a link for a video prepared by us showing how this is all done, if anyone's interested. And in terms of how we do rescue ICSI, we do late rescue ICSI, and we only do it in cases of TFF. It's done 22 to 24 hours after conventional IVF, using the previous day's sperm sample. Fertilization is then assessed the following day, and any subsequent embryo transfer or vitrification decisions are made on an individualized basis. If we quickly compare early and late rescue ICSI, early rescue ICSI is done about 4 to 8 hours after conventional IVF. Generally speaking, it's got better clinical outcomes, however, it does carry the disadvantages of being less practical in terms of timing and also high risk of polyspermy. Late rescue ICSI is done about 24 hours after conventional IVF. Practically speaking, it's better, it's easier timing-wise. And also, the overnight incubation of oocytes may allow some immature oocytes to reach maturity. However, some of the disadvantages are oversize aging and endometrium embryo asynchrony, which is why deferred transfer is often considered. Based on our own clinical experience, we also developed our own conventional IVF index. This is a simple and objective way to decide which couples are for conventional IVF and which for ICSI. It uses the 4 basic semen parameters of volume, concentration, progressive motility, and morphology. If a couple has an index above 100,000, then we prefer conventional IVF for them. If below this, we do ICSI. So moving on to a study that we did to see if late rescue ICSI can overcome TFF in conventional IVF. For this, we reviewed about 2,000 conventional IVF cycles in our clinic between January 2015 and June 2025. TFF occurred in 98 of these. 13 of these cases were excluded because of poor oocyte quality or immature oocytes, as they weren't eligible for rescue ICSI. And in the remaining 85 cases, late rescue ICSI was done, involving 329 oocytes. 7 of these cases remained in TFF, and fertilisation was achieved in 78 of them. That says 29, but I think that's meant to be 26. So 26 underwent freeze-all for embryo pooling, and embryo transfer was cancelled in 11 because of poor oocyte quality. And in the remaining 41 cases, fresh cleavage embryo transfer was done, involving 48 embryos. And this gave us 2 live births, 2 miscarriages, and 2 ongoing pregnancies. So that's a pregnancy rate per embryo transfer of 14.6% and implantation rate of 10.5%. Of the 2 pregnancy losses in this study, one was in a 32-year-old with a previous history of spontaneous miscarriages. The other one was in a 41-year-old. In terms of the ongoing pregnancies, one's a twin pregnancy at 25 weeks currently. The other's a singleton pregnancy at 27 weeks. In terms of the live births, both were in patients with low ovarian reserves. And if we look at the baseline characteristics of our TFF patients, just a couple of things to highlight here. Ovarian reserve was generally low, and also there was limited oocyte yield. Some general points from the literature regarding TFF. TFF remains in many cases unavoidable, unexplained, and unpredictable. However, luckily it's not always recurrent. And if we look at the 2 main systematic reviews for rescue ICSI, the early one shows that early rescue ICSI gives better clinical outcomes, pregnancy rates, than late rescue ICSI, but delayed transfer improves pregnancy rates in late rescue ICSI. So, in conclusion, the take-home messages are: fear of TFF is not a good excuse for routine use of ICSI in non-male factor infertility. TFF is not unique to conventional IVF, it can happen in ICSI as well. And day after rescue ICSI, so late rescue ICSI, can salvage TFF cycles and allows conventional IVF to be performed with more confidence. Thank you for listening.
Thank you. Oh, sorry. Thank you. That was a fantastic talk. Thanks so much. There's some time for questions. I think somebody's stood over there. If you can wave at us, thank you.
Hi, I'm Dr. Edem Ajir from Kosovo. First, I would like to congratulate for your presentation. I would like to ask, how did you choose the cutoff of 100,000 spermatozoa for a conventional IVF index?
That's just based on our own clinical experience. It's not based on any mathematical formula as such, which is why I guess the true cutoff could very well be slightly below this at maybe at 90,000 or slightly above at 110,000. We don't know, but for us, we find that it works.
Thank you.
Thank you.
Question over here.
Thank you so much for the wonderful presentation. Why were fresh embryo transfers performed and not frozen after late rescue ICSI?
Oh, that's because at the time that these patients were treated, I think kind of our clinic's protocol was to perform fresh embryo transfers, and much of the evidence suggesting better pregnancy outcomes with frozen or delayed embryo transfer came after this, so this wasn't really reflected in the clinical practice at the time.
Thank you.
Another question here.
Here.
Hello. Very nice talk, thank you. I just have a comment, I don't have a question. I just wanted to correct the information with 0% IVF in Middle East, because it's been always presented as such, and it's not true. So we perform IVF, yes, in very maybe low amount and considerably in the area. However, it is done in according to the need. So we have at least 10% IVF in our clinic, but we have many male factor patients, so that's why we do. Thank you.
Okay, thank you.
Thank you. There are more questions over there.
Hi there, Jessica from Germany. Thank you for your talk. I want to ask the semen you take for the IVF, you also take it for the ICSI, the rescue ICSI, or does the man give a fresh probe?
Well, so we use the previous day's sperm sample.
The same.
I understand the kind of lifespan of sperm is long enough that we can do late rescue ICSI and use the previous day's sperm sample. So just for practicality reasons, we don't call the patient in again.
Okay, thank you.
Okay. Here, please.
Hi, Oluwatosi from Nigeria. I was just going over your presentation and I wanted to ask, why would you put the patient through rescue ICSI when you can actually do the ICSI? Because if you look at the data you presented, only 2 live births. And why would you decide to do conventional IVF in the first place?
Well,
because if you look at the emotional effect, cost, and everything, you have to put the patient through that when you can actually just optimize. Second, I would ask, if you keep the sample on the bench overnight, have you noticed any growth in the semen sample? Don't you think that can also affect the rescue results?
Yeah, so the ethical side of things is definitely important to consider. However, I just want to reiterate that TFF rates between conventional IVF and ICSI are similar. And in fact, one of those RCTs I've shown you, conventional IVF has a lower rate of TFF than ICSI. On top of that, we should also consider other laboratory parameters. So conventional IVF is known to have either similar or better outcomes in things like implantation rate, pregnancy rates, live birth rates. On top of that, ICSI has higher risk of congenital anomalies, chromosomal abnormalities, higher risk of polyploidy. So putting this all together, I think in non-male factor infertility, conventional IVF is still the better option. And in terms of our late rescue ICSI statistics, since you refer to them, I agree they're quite modest. However, let's not forget that these patients experienced TFF, so would have had no embryos at all if it wasn't for late rescue ICSI. On top of that, if you look at the baseline characteristics of our TFF patients, they represented a poor prognosis group given their low ovarian reserve and oocyte yield. So if late rescue ICSI can salvage some TFF, some cases in such a group, then I guess that's still, even if it's not effective per se, it gives a glimmer of hope.
Okay, but do you consider? Okay.
Questions? It's a very interesting topic. Thank you for answering. We're going to move now to the next speaker, Danilo Cimadomo from Italy. We'll talk about the clinical value of the 1pm embryos in IVF.
So thanks for the introduction. Thanks for choosing this abstract for a talk. First of all, I'm presenting on behalf of ICSI Gastrom. So this, to be totally honest, this is data from the Livio centers in the Nordics. So the topic of the talk is the problem of atypically pronucleated zygotes, what to do with them. We know there are three, basically, let's say 2 kinds of them, monopronuclear ones, 1pm, so-called 1pm, and then embryos with 2 or, let's say, 2.1 or more than 2 pronuclei in general, the so-called free PN. The data when it comes to free PN embryos or more tell us, according to this systematic review that we draft together with Antonio Cabalbo, Cristiano Ottolini, and Giovanni Coticchio, that if they get to blastocysts, and they get to blastocysts quite often, the diploidy rate is about 50%. Although when it comes to free PN embryos, few of them have been transferred to date, and we just have reported in the literature 8 live births, healthy live birth, but just 8 live births. Which is the reason why perhaps ESHRE and Alpha said that preclinical research and pilot clinical study perhaps are still required when it comes to free PN embryos. This is mostly due to the fact that the risk of triploidy on maternal morbidity, miscarriage, and molar pregnancies, these kind of problems, are quite relevant to justify two-core use of these embryos. When it comes instead to 1 PN embryos, they get to blastocysts less often, but if they get to blastocysts, 71% of them are diploid. And there have been reported quite a few live births, over hundreds of live births to date, after both tested or untested embryo transfers, which is perhaps the reason why ESHRE and Alpha said that a cautious clinical use is recommended for these embryos, especially if you conduct blastocyst culture, and if available, PGTA is suggested. This is the most recent meta-analysis from a Chinese group. They put together all the data in the literature published in ESHRE this year. And you can see that the data that have been reported on these 1 PN embryos account for about 3,000 zygotes cultured to blastocyst and 1,000 embryos transferred. Now, they have a lower blastulation, they have a lower live birth, but the miscarriage rate is similar, the euploidy rate is similar, and there is no difference in terms of malformations when compared to 2 PN. So basically, in the worldwide scenario, we are moving, though, and this is relevant for technical aspects, from static morphology, when you have a snapshot in a given time frame of the presence of the pronucleus, and if you do PGTA, copy number variations, to a situation in which we use time-lapse, so you have a continuous monitoring of these zygotes, and if you add ploidy analysis through genotyping, so SNP array, you can actually check on top of copy number variations if they are haploid, triploid, or diploid. So the idea is that we might be rescuing these embryos more often. The problem is that a one-size-fits-all approach perhaps is not feasible because they increase cost, workload. The counseling especially is challenging, and I will touch upon that at the end of the slides. We might be freezing embryos, surplus embryos of unknown competence, and the true clinical benefit is still required to be defined. And then there are situations like Sweden, which is part of this study, in which PGTA is not allowed. So what to do in those cases in which PGTA is not allowed? So that's the reason why we designed this retrospective multi-center study. We collected data from 7 Swedish clinics from Livio Group and 1 from Iceland. It's 15,600 couples. 17% of them affected from male factor infertility, BMI 25, maternal age 35 years, so quite young, especially if compared to the Italian population. And we're talking about 448,000 plus COCs that have been used across 46,000, almost 47,000 cycles with either IVF or ICSI, but all with time-lapse culture. Okay, so the definition of 1 PN in this study, it's very clear based on a video. No PGTA involved, as I told you. It's almost 7 years, 8 years collection. So you see that 2 PN zygotes are 218,000 compared to 13,000 1 PN embryos. And if you remember the data from the meta-analysis, together with a study that has been published by Dean Morbeck last week, this study alone accounts for more than the data reported from the literature to date collectively. So the prevalence is about 3%, but 22% of cycles will happen to have at least one 1 PN zygote available. If you culture them to either day 3 or blastocyst stage, the 2 PN embryos will develop to a usable embryo in 43% of cases, while the 1 PN, 10%. that means that about 3% of the patients will have at least one 1PN usable embryo. Okay, so this is just to give you an idea of the numbers of patients we might be facing with this situation. Obviously, IVF or ICSI does make the difference, because with ICSI we have a lower prevalence of COCs that develop in 1PN zygotes, almost half with respect to ICSI, and the blastulation rate of 1PN embryos derived from IVF is twice as much than compared to ICSI. And this also is confirmed by the data that Dean Morbeck published last week. So in terms of transfers instead, only first fresh embryo transfer, if performed, accounted cleavage stage. Otherwise, they were all blastocysts, meaning that blastocysts could be transferred fresh, but all vitrification were blastocyst stage. Only more than 3 BB in terms of Garner score. This is important because the selection in Sweden is quite aggressive, at least as compared to Italy. And 1PN embryos were transferred as last chance in case of non-availability or no live birth after 2PN. Up to date, they've been transferred almost 500 embryos derived from 1PN, mostly at the blastocyst stage. And if you remember the data from the meta-analysis, it's almost half that what has been reported up to date collectively in the literature. Compared to 2PN, the live birth rate is quite similar, 30% versus 34%. And when adjusting for confounders and also conducting a propensity score matching analysis, there is absolutely no significant difference in terms of live birth of 1PN, especially if they are blastocyst stage versus 2PN. But again, there are very important differences according to the stage of transfer, where blastocyst is much better than cleavage, because many 1PN embryo will degenerate in the transition between cleavage stage and blastocyst stage. And again, IVF is better than ICSI in that perspective, because if you see this sub-analysis, 2PN embryos at the blastocyst stage from IVF compared to 1PN embryos at the blastocyst stage with IVF at the exact same live birth rate. And the numbers are quite good. We are talking about 351 embryos derived from 1PN. Now, what can we tell then about counseling? And I'm approaching the end of the presentation. If you see this pie chart, in orange you have the patients that have, out of the total, at least one 1PN zygote, but in blue you have the patients that have at least one 1PN embryo. Okay? So if you mention to the patients in day one, so you imagine you have a counseling strategy in day one, the possibility of using these embryos, in those 9 years in 8 centers we would have had to talk with over 10,000 patients, projecting them the, let's say, a 3% chance of a higher possibility to have a baby. I'm not talking about second babies, a chance of having the first baby. If we instead move the counseling to day 3, but most probably and preferably day 5, then you would talk with 8 times less patients, 1,200 roughly, and you can prospect them a 20% increase in the chance of live birth if using 1PN embryos. So this obviously makes a huge difference. And if we are talking with patients that are older than 42 in this sub-analysis, the chance of live birth can get as high as a 25% almost increase. Now, this being said, the conclusions is that this is the largest analysis, together to the one that Dean published last week, published to date in a multi-center setting about the clinical value of 1PN embryos. 1PN zygotes deriving from conventional IVF are different from the ones derived from ICSI. 1PN zygotes have substantially lower developmental competence compared to 2PN. But if cultured to blastocysts, and especially if originating from IVF, 1PN embryos show comparable live birth rate than 2PN. Now, if the decision-making point is postponed to day 5, let's say, and at least one 1PN embryo is obtained, then we would counsel 8 times less patients and project them a 20% increase of live birth. Limitations are that this is a retrospective study. Because of the law, we couldn't apply PGTA. Morphodynamic patterns have not been investigated, but as part of an ESHRE grant we got 2 years ago, we are designing an AI tool to do that automatically, and so that will be part of the follow-up study. Neonatal outcomes have not been reported here, but we are collecting them, and I can tell you that there are no differences. Cost-effectiveness analysis is recommended, but we published last week actually with Antonio, Christian, Ottolini in Fertility and Sterility that in the data set of General Rome, at least there was no difference actually in terms of cost effectiveness. Okay, so you can use these embryos and it doesn't increase the cost compared to the higher chance of live birth you would have. Just a last slide. We were at the session before from ICMAR WHO about the new glossary. Do not talk about abnormal fertilization because that will be perceived as something that is not normal to the patient, and talk about atypical because these embryos can make healthy babies. And I'm just concluding by obviously thanking all my colleagues, Aisling that she couldn't be here, and all the team in Livio Clinics because this is their data, and ESHRE also for partially supporting this study with the ESHRE grant, and you for your attention.
Thank you, Danilo, for your talk. While we are waiting for questions, I have one question. So, looking at results and looking at those embryos that have been fertilized by conventional IVF are comparable, did they change their policy? They give preference to the ones to those embryos that came from 2 PN instead of 1 PN? They decide depending on the morphology?
Now, well, I think that especially when it comes to the absence of PGTA, we should still give preference to PN. Then the other thing is that this is a very young maternal age population, so PGTA might not be beneficial below 35 years old because you simply have more embryos. Still, I would prioritize the 2 PN embryo in any case. Okay, but that being said, it's less of a problem to deal with 1 PN because if they are haploid, they will not implant, just fail to implant. Although it has been reported that some of them might be triploid, with a single pronucleus but triploid. That's the reason why I would, when possible, still suggest PGTA and still suggest that they are deprioritized with respect to 2 PN.
Okay, thank you. We have one question there.
Hi, Danilo. Great study. Thank you so much. It's over here, to the left. Kind of. So I was wondering if you looked into the size of the pronucleus, because I have an idea that it can be a relevant parameter.
Well, there's actually a great question, Miguel, because that's part of the follow-up study we're doing on morphodynamic analysis automated through AI. So, now we have a large data set that we can use, and, the feeling is that the size of the pronucleus is, associated with the developmental competence and the diploid constitution, actually, of the pronucleus. And Dean Morbeck did, I know if in the whole data set or in a subset of the data, but he reported that indeed there is an association. So, and not only the size of the pronucleus, but also the nucleoli within the pronucleus, how they are, if they are dispersed, if they are aggregated and things like that. So there is a lot of information that can help us, can guide us in the prediction and perhaps in the counseling and the clinical use of these embryos that we can get from videos and that we didn't have time to look at during clinical activity today, but AI will help us in do that in a data set like this. 100,000, over 100,000 videos could be analyzed like in a matter of weeks.
Okay, and just to be clear, the association is bigger, is more likely to be chromosomally normal.
Correct.
Okay. Thank you.
If there's no more questions, thank you very much.
Thanks.
Okay, we have our final speaker now, Leanne Nesbeth, and she's going to be talking to us about the clinical utilization of atypically fertilized embryos.
So, afternoon everybody, my name is Leanne. I am a trainee clinical embryologist in the final year of my training. I did this small piece of research as a part of a requirement for my master's degree at Manchester Metropolitan University, and I work at Lister Fertility Clinic. I have nothing to declare. So this topic is about how we counsel patients regarding our atypically fertilized embryos. So with a little bit of background, for fertilization assessment, we're looking for the 2 pronuclei in the center of the zygote and 2 polar bodies. Anything that looks different to that we class as atypically fertilized. So this is inclusive of 1 PNs, 2.1 PNs, 3 PNs, and anything with 4 PNs or more. For the purpose of this study, I only focused on 2.1 PNs, 3 PNs, and 4 PN or more categories. So the potential causes of this type of fertilization is if there's errors in meiosis, so if we have diploid gametes that have fused together, the instance of polyspermy, so this could be due to a too high in-sem density, or if the oocyte has failed to undergo the cortical reaction, so the zone of pellucid is not preventing the penetration of multiple sperm. If the second polar body does not extrude, or if it has extruded and then it gets reabsorbed. So considering these potential theories, then we would suggest that these atypically fertilized embryos are potentially genetically abnormal. And our question is, are these actually clinically relevant? Because historically, we would just kind of discard these embryos. So clinical relevance, in the past, I would say decade, there's been an increase of number of research regarding these embryos. Some studies have reported 30% euploidy rate of 3PN embryos. We see approximately 27.5% euploidy rate of 2.1 PN embryos and showing live births. And I included that case study, which I thought was interesting, where a 4 PN embryo was transferred and resulted in the healthy birth and normal development of a baby boy. So then our clinic policy at Lister Fertility, we changed this towards the end of 2023. So our fertilization assessment occurs at 16 to 17 hours post-insemination, and we include zygotes created from ICSI and IVF. All of the embryos were cultured to blastocyst stage, and all of our patients understand that they can only be used for pre-implantation genetic testing. Any genetically normal blastocysts that we get can then be used in a future frozen embryo transfer cycle, and they won't be deselected against. So the study period was from January 2024 to January 2025. I looked at approximately 598 cycles. This was from around 550 patients, and we had 961 atypically fertilized embryos. So we looked at the blastulation rate, and we looked at the utilizable blastulation rate. We found that approximately 12% were making it to that utilizable rate, which we in our clinic class as a 3cc using Gardner's grading system. And then moving forward, approximately 10% of those were biopsied, and the attrition rate was mainly due to patient choice. So when we're looking at euploidy, we're looking at diploid euploid. For 2.1 PNs, we found 20%. 3 PNs were 28.6%, and that 4 PN or more category was it was 40%. So the data was compared using cross-tabulation, and we looked for significance using chi-squared, and we didn't find any significant associations between a specific PN category and the ploidy status. So I think from this small piece of research, we've seen that these embryos are capable of reaching the developmental milestones, and that morphological assessment may not always correlate with genetic competency. That's not necessarily only due to the blastocyst stage grading, but maybe also at the zygote stage. Obviously, this is interesting research, but we need to consider the limitations as well. So firstly, this project wasn't refined in the context of maternal age, and whenever we're discussing genetic testing and euploidy, we always need to consider maternal age. It was a single-center study with a very low sample size. There wasn't specific standardization between how we classed a 2.1 PN embryo and how we classed a 3 PN embryo, so this is open to a degree of subjectivity. The 4 PN or more category is quite inclusive, and that was mainly due to numbers, but as scientists, we can't confidently say a 4 PN embryo would behave the same as a 6 PN embryo. And lastly, I didn't consider confounding variables, meaning that multiple embryos could have come from the same patient, but we didn't account for this statistically. So to conclude, approximately 14% of the blasts made it to utilizable quality, and approximately 29.5% were classified as diploid euploid. I think the extended culture of these embryos could rescue a patient's cycle, but I think huge significance needs to be placed on counselling these patients appropriately. We also need to, when counselling the patients, we need to discuss the potential limitations, just so they know where our limits are met in terms of the knowledge with using these embryos. And I've just included a picture for you of a 2.1 PN embryo that made that beautiful blast, and that resulted in a live birth. And lastly, I didn't include it on the slide, but in terms of that first year of us doing this, we transferred 11 embryos that were atypically fertilized, and we had 5 that resulted in a live birth and 1 in a miscarriage. Thank you.
While we're waiting questions, I have a question. First of all, thank you for putting that here in this paper and analyzing the diploidy, or the aneuploidy of these embryos. We are doing an update in the SIG of embryology from the Atlas of ESHRE. So it would be very interesting if you take measurements about the micronuclei. Did you take that?
No, we didn't. And it was mainly down to time and just the scope of what was required for this project. But going forward, for any future research, especially in this realm, me as a reader, I would expect to see that as well. So that's something we'll do.
Oh, got someone over there, actually.
Hi. Congratulations on the presentation. I'm Kirti Rupa, one of the embryologists from GUYS here in London. And I just wanted to know, for the patients where these atypical embryos were eventually transferred, what was the number of normally or typically fertilized embryos that you had? Was there any cutoff on maybe having those, or any thought about that?
Sorry, could you repeat the question?
Yeah, I'm trying to ask if there was a cutoff on the number of 2PN typical embryos you had for these patients where these atypical embryos were eventually transferred, or was there any cutoff for that?
No, there wasn't a cutoff. So once the embryo came back as genetically euploid, we would consider them on the same level as typically fertilized embryos. So there wasn't a cutoff.
I have a question, Leanne. Also, well done for doing this presentation. Now, you must have your final assessment imminently, I think. I'm assuming a lot of pressure. I think I'm possibly asking the same question, but I'm not sure if that was the answer we were wanting.
Okay.
If somebody has typically fertilized embryos, 2.1s, 4PNs, you will still offer PGTA for those other embryos?
Yeah, so we give patients the complete choice. We give, whether it's they only have atypically fertilized, whether they have majority 2PNs, we give them, all of them, the option.
Okay. And is it quite difficult to counsel them towards that? Because I appreciate they have to have PGTA if it's a 4PN embryo. Yeah. Is that quite a difficult counselling session because it's quite a quick decision?
It's very difficult to counsel them. And I think the previous talk, talking about the discussion on day 3 was really interesting because that's also something we implemented. So we mention it on day 1, and then we go further into it on day 3 if we do see they have atypically fertilized. So yeah, the counselling is very difficult, but we do also offer the option for the patients to just cryopreserve those embryos with the future idea that they will thaw biopsy refreeze them if they do need to use them. So they kind of have all of the options.
I have a question here, Susanna.
Zuzana from Czech Republic. I was wondering, in your cohort of embryos, did all of them originate from fresh oocytes, or were there any frozen thawed oocytes too?
There were some frozen thawed oocytes. From the top of my head, I think it was about 5%, so it wasn't very significant in terms of numbers.
Because in terms of origin, how this multinucleation arises, could you speculate if it would be possible that there were some errors during second meiosis, that the spindle pole heading towards the oocyte split it and generated 2 pronuclei instead of 1, but genetically this would be correct number of chromosomes?
I mean, it's a good question, and goes into part of our patient counselling as well, because they always want to know why. Obviously, there's no way of us actually knowing the reason why we're seeing atypically fertilized embryos, but that could potentially be a reason. I didn't hear at the end.
Because this would be those euploid embryos in your results, 2.1 embryos, but euploid.
Yeah. Thank you.
Question.
Hi, this is Adrian, an embryologist from Hungary, and I was wondering, you have mentioned that in the end that you had 5 live births. Do you have information about the baby's health status? Did they have any genetic disorders or something?
I don't have the information. We're still consolidating that data, but nothing has been kind of alerted to me. But I wouldn't say confidently. I'm not sure.
Thank you.
Thank you.
Any more questions? No?
No.
Okay, well, thank you very much to our last speaker and all of our speakers this afternoon. Thank you.